So, hi everybody, welcome to today's Independent Stage briefing. It does seem clear now that we have entered another wave of COVID infections, and that means COVID is going to be harder to avoid as we go into the winter months. So today I'm going to be asking each member of Independent Stage what they see as like the biggest COVID-related challenges over the coming months, and then we'll move on to another great set of questions from the public. But before that, Dr. Duncan Robertson will share with us the latest COVID numbers and set the context for today's discussion. So over to you, Duncan.
Thank you very much. So these are the kind of headlines for today. As Christina mentioned, we're at the beginning of a new COVID wave, and we can see that very clearly in terms of numbers of people being admitted into hospitals. We're starting to see that in the slightly older data from the ONS infection survey. It's not clear that this is driven by a new variant, but we can see that there's pressure mounting, not only in number of people going into hospital, but we're starting to see number of COVID occupied beds increase as well. And I think the way to kind of resolve this is vaccination, but we're still seeing huge disparities in vaccine take-up, and I might mention that at the end. So, in terms of people testing positive, this is from the ONS survey, so this isn't dependent on random testing. So this is random testing, so this is fairly representative of the population as a whole, and we're seeing a starting to increase in England and in Wales. And in Northern Ireland and Scotland, it seems to be, potentially falling or keeping the same. So we're really seeing that this is in England and Wales. This is up to the 14th of September. So this is, now 9 days old, this data. But we are starting to see, certainly in England and Wales, an increase. And in terms of who is actually causing this increase, we can see that there's a particularly high increase in school year 7 to 11. This is potentially what's driving this wave. Of course, children have gone back to school. We're not seeing it in younger or older school children, so it's slightly odd that it's kind of concentrated there, but we are certainly seeing a significant increase in that age group, and we're also seeing within 25 to 34-year-olds as well. So we can see the increase is happening in those two age groups predominantly. In terms of where this is starting, we're seeing regional increases. And I think what's kind of interesting is we'll see some data from hospitalizations, for example, in the southwest, which are increasing significantly, but we're not quite seeing that in the ONS figures, perhaps because the ONS is lagged compared to the hospital data. So there's some kind of inconsistency between hospital admissions and the ONS data. So onto that hospital data. We're seeing, say September the 19th, we've seen kind of a significant increase in number of people admitted to hospital, and the sort of moving average, which takes into account the ups and downs through the week, is also increasing. So we're starting to really see, the beginning of a new wave, and that wave is feeding through into hospital admissions. So, there's a certain lag between people being infected and going into the hospital, but we are seeing that hospitalization increase. And in terms of who's going into hospitalizations, it's mainly driven by over 65s. And these, of course, are people who are potentially most at risk on average from COVID. And there are regional variations. So, for example, northeastern Yorkshire, the southwest, we can see there's a significant increase in the rate of people admitted. And we can see, if we zoom into those, on the left we have the southwest, and on the right we have northeastern Yorkshire. So we can see those increasing. And as I say, particularly on the sort of September the 19th, which is the latest date, we can see these significant rises. So it's going up significantly, certainly in those areas. In terms of occupied beds, which is the kind of, as well as people going into hospital, the number of people in hospital, that's increasing. And we can look and split that down into the number of people who are being treated for COVID and the number of treated people with COVID. So even the number of people treated for COVID is increasing. So this isn't just an artifact of more COVID in the population. There's no real signal in terms of people who are perhaps the most ill in mechanically ventilated beds. We're not, there's a potential uptick, but we're not quite seeing that yet. It may feed through in the future, but we're not really seeing a definitive increase so far. In terms of variants, we would perhaps, if there is a new wave, we would like to know what the variant is that's causing it. This is in terms of the variants that we have. So a lot of people who are being sequenced at the moment have BA5, but we're not really seeing anything significant coming to replace it. So there are lots of potential variants that might be causing this, but we haven't really got a clear signal about which of those variants is dominating so far. So we might need more data and more weeks to know whether this is driven by immunity decreasing in the population or potentially another variant of concern. In terms of vaccination, where we are at the moment is we have the autumn 22 booster campaign. So this is what's happening in terms of over 65s, and the most vulnerable are being invited to have their autumn 22 booster. And we can see that it's got to just under a quarter of over 75s and about 1 in 10 65 to 74-year-olds. So we'd expect this to increase over time as more and more people get round to getting their autumn 22 booster. We haven't quite seen eligibility reduced to the over 50 or 50 and overs, but we hope to see that soon. So this is for over 75s, and we can see, this is the population, relatively low numbers, which are unvaccinated, and we can see that how those people, roughly 1 in 5, 1 in 4, have had their autumn 22 booster. So of course, this is immunity that's increasing from first dose to second dose to booster to subsequent boosters. And we can see actually after a long period of very, very few vaccines given, we're starting to see that uptick in the number of people being vaccinated per day, up to just around 200,000 being vaccinated per day. So this is very much the campaign of the autumn booster taking effect. So it's good to see, but of course, it requires people to come forward for those vaccines in order for that vaccination drive to have effect. And this is really splits down into the number of people who've had doses of COVID. So the number of people is from left to right. So, as you go through the ages, there are a different number of people in each of those age groups. And we can see that the number of people who aren't vaccinated increases as a proportion as you go lower down the population. So we have very low number of people that are not vaccinated in the higher age groups, and very high numbers of people who are unvaccinated in lower age groups. And of course, this doesn't include 0 to 4-year-olds who aren't currently eligible for a vaccine. One thing that's maybe Zubaida will come on to more is the disparities. So this is a chart that we've seen for quite a long time. But you can see 91% of white British people have had a vaccine, and that compares to perhaps 1 in 3 amongst other groups. So we actually have a huge disparity between the number of people who are unvaccinated. So just to clarify that, so 35.8% people for Asian or Asian British Pakistani groups who are unvaccinated, 77.6% white British who are vaccinated. So you can see there's huge disparities, and that's something that is of importance. And one thing that I think is really interesting is what causes this. So if you look at children, so 12 to 15-year-olds who are vaccinated or not vaccinated. So the red in this chart shows the proportion who are unvaccinated. So you have more than half who are unvaccinated in the most deprived groups, and 1 in 5 who are unvaccinated in the least deprived group. So you can see that if you're a child, whether you're vaccinated is heavily dependent on your index of multiple deprivation, how deprived you are. So this is, of course, important. But I think another finding is that for these 12 to 15-year-olds, what causes you to be vaccinated? Well, your parents have a huge influence on that. So if your parent hasn't been vaccinated, you have a 95% chance of not being vaccinated as a child, compared to if your parents have had the autumn 2021 booster, the one a year ago, then there's only 18% who are unvaccinated. So huge amounts of disparity in terms of deprivation, and also not independently, there is the amount of variation that's caused by your parents not being vaccinated. So there we are, that's where we are. We're at the beginning of this new COVID wave. It's not clear there's a variant that's causing this, that's definitive. Infections are increasing in England and Wales, not quite so sure in Scotland and Northern Ireland. Hospital admissions are increasing, driven by over 65s. The number of people in COVID beds is increasing, and there are still huge disparities in vaccine take-up. So I'll pass over to you.
Thanks, Duncan. Yeah, those vaccine disparities are quite something, aren't they? So, you know, as we enter into our third winter of COVID, our fourth wave this year, I want to ask each of you, you know, what you see as the big challenges over the coming months, whether that's, you know, for your work personally or the country as a whole. So I'm going to start with those people working in the NHS. So Helen, over to you first.
Hello. So what does COVID mean for us now? Well, one is another round of giving booster vaccinations, which is more work, but work we're very happy to do. And we were slightly concerned about whether, yeah, because COVID, there's a real sense in the news and the media that it's all over, but clearly patients don't think that, because actually they're coming forward for their booster vaccines. We've been, you know, everyone wants to get their boosters, which is great, and we want to give them their boosters. So we'll carry on, and that's going to be quite a lot of work for us. I think the other issue for us really is that this rising cases, and we're really seeing it. And partly we're seeing it just because our staff keep going off sick now. That's just upticked now, particularly staff who've got kids at school, small kids. Those staff are now getting COVID, and it becomes a juggling act trying to fill the clinics with your available doctors. And I think that'll happen across the NHS. If there's more COVID in the population, then there's more COVID in the workforce, and we struggle to get the work that needs to be done. And we know there's a huge backlog, and it's going to get very hard to eat into that backlog when staff are sick. And I think that's really the main thing that's affecting us now.
Okay, thank you. And before I come to Benita, I just want to go to Steve Griffin first for his view.
Thanks, Christina. Well, I mean, for me, and obviously my research interests are on therapeutics, so I do think these are really important to get right, because they are a key aspect of our so-called living with policy, because where the vaccines don't protect, particularly in clinically vulnerable people, the therapeutics are meant to do that job. But the question is, are these robust enough for them to do this job at the moment? And some people just kind of become a little bit dismissive of the clinically vulnerable populations because they've got the therapeutics. Now, it's definitely the case that we've got fantastic advances in these areas through the pandemic. The ones I'll focus on really are the monoclonal antibody therapies and the direct acting drugs, which hit the virus specifically as it replicates. And these are different to the sort of immune modulators that people with very severe disease have to tone down that adverse reaction. I think the major issue is, are the right medicines getting to the right people? There are lists of people that are eligible. They're quite prescriptive. They're not necessarily nuanced enough. There are differences in supply and treatment pathways. So you'll be given a different drug if you go via the community or the hospital. There are still trials ongoing. And really, medics are having to really think on their feet with this, because it's really hard to do. The monoclonal antibodies work really well, but they vary differently against different variants. And what we need is robust assessment of their clinical efficacy almost in real time, because we don't want to dismiss a medicine that could otherwise work. There's another aspect to this. There's this wonderful Evusheld therapy, which is a prophylactic, which could give people months of protection. But unfortunately, despite it being approved, we've not had that given. So the last bit is that we have these drugs that you give very early to protect those at risk, these ones that work directly on the virus, but they're very, very good at preventing that severe disease, but they're not perfect. Molnupiravir doesn't work as well as some of the others. Remdesivir has to be given in your veins, and Paxlovid has a drug in it that affects the way you process other drugs. So it limits the number of people that we can have. So it really is difficult, because we've only got these drugs given in isolation, and the danger of that is that we will see resistance one day. So I think the major focus for me is we need to get these to the right people, but we also need more research, more drugs coming through the pipeline, so that we can give rational combination therapies in the future going forward to protect people who aren't protected by vaccines.
Okay, thank you. Something to think about. So Vanita, working in a hospital setting, what's your perspective of this winter?
Yeah, I am really worried about the winter period. And I think what perhaps people don't appreciate is how much every COVID wave we've had so far has hugely impacted on the NHS already, bearing in mind we're in wave 8 now, I think, and we're just heading into another winter where we're expecting flu as well on top. And I think, firstly, every time there is a wave and the hospital beds fill up, it kind of impacts on other activity like operations and outpatient clinics. So the acutely ill patients get put in the surgical beds, and also we have to cancel our clinics to free up us to go and look after the additional patients on the front line. So that adds to the backlogs, and over 2 years we've never been able to catch up with the last backlog before the next wave hits. So it's kind of ended up with this cumulative effect of ever-growing waiting lists. And as Helen has already alluded to, I mean, we had a massive workforce crisis in the NHS before the pandemic, and that was compounded by Brexit. We lost a lot of European staff, but with each wave, we also lose NHS staff. So I think last winter, we were running at something like 10, 11% staff sickness rates at a time when we were busiest, which again just adds to the pressure. And then with each wave, we also lose staff to chronic illness through long COVID, and there's also a lot of burnout and stress, and people are really demoralized. And this, of course, spreads into every sector. So it's not just hospital, it's the ambulance trusts, which are in crisis up and down the country, it's primary care, it's the social care, and all of that creates further pressure on the acute care system. And so it's kind of this perfect melting pot. And people say, well, the NHS has coped and it's coped, but we're not coping. We're seeing now routinely 12, 14-hour waits in A&E, and these are kind of frail elderly people a lot of the time. And it breaks my heart actually seeing patients so sick and vulnerable and not being able to care for them in the way that we would like to. And I think finally the other thing I'm really worried about is the fact that a lot of the tools that we've had over the last couple of years to plan our services have been scaled back and stripped away. So the surveillance and the intelligence about COVID rates and what's happening in our local population. And if you use supermarkets as an analogy, supermarkets very carefully monitor demand and capacity. So at Christmas, we know we need more turkeys, and we know how many. We open more tills. We just can't do that in the NHS without that intelligence. And so you're kind of flying blind. If you're a commissioner right now, it's very hard to plan for a winter crisis when you don't know what it's going to look like. So that's another additional difficulty that we're facing.
Okay, thank you. So, I mean, we're thinking about flying blind, and it's kind of more of a structural issue. So let's kind of dig into that a bit more, and I'll come to you, Duncan, first on this.
Just really following up from what Vanita was saying in terms of surveillance. So we've seen that the amount of surveillance that's being done has dropped off. We thankfully do have the ONS COVID infection survey. So if we didn't have that, we would have very little information about the number of cases in the UK. And also in terms of sequencing, so we're looking to see, what's the next variant that's going to come along. Sequencing has decreased, so we don't really know, as much as we did, what the new potential variants are. There is still sequencing, there is still the ONS COVID infection survey, so thank goodness it hasn't stopped altogether. And of course, I think there was a sort of mantra from politicians about data, not dates, and there's nothing in the data. you know, there is still data there. So it's not really in front of the public, but that's, I suppose, what you know, Independence Age is doing, getting some of that data across. So we don't really know if there is a plan for winter 2022. And we don't know, you know, heaven forbid, but if there is a resurgence of a variant that does, you know, escape immunity very significantly, puts more people in hospital, what are the thresholds for action? We don't really know what they are. We don't have reports from SAGE in terms of minutes from them anymore. And really, I think, you know, it's not just the number of people with COVID, it's the number of people who are off sick with COVID, as Helen was mentioning as well. So surveillance, thank goodness we have some, but not as much as we did.
Okay, thanks. So Aris, what kind of impact is that surveillance having on us kind of tracking new variants and the like?
Yeah, so I mean, at the moment, we're in a very fluid and unpredictable situation regarding what's going on with SARS-CoV-2 and the direction that future variants might take. And all this at a time when testing and surveillance is being scaled down substantively, despite the impressive efforts of teams around the world to do the best they can with this data, right? But I mean, regarding what comes next and what we might see during the winter, there's a lot of uncertainty. I mean, we saw in the first 2 years of the pandemic, these really clear patterns with a sequential succession of Alpha, Delta, and then Omicron. But now we're seeing a rapid proliferation of multiple descendants of the Omicron lineage, including some so-called second-generation variants that are, while they're descended from Omicron, they're actually quite distinct, both genetically and in terms of how they interact with our vaccines. So in a sense, no one variant seems to be taking over entirely, but we've got lots of subvariants of Omicron that are separately all doing reasonably well at the same time. So what happens next? Are we going to see sequential changes in one of these sublineages of Omicron? Is something quite distinct going to crop up with distinct pathology potentially or immunology? And most importantly, what is this going to mean in terms of how well our vaccines hold up in the longer run? And we don't know, and all this at a time of rising case numbers, which itself favors the generation of more forms of the virus. So really, there are a lot of questions and unknowns regarding what variants are going to do to case numbers and to the course of the pandemic over the winter. Thanks.
So, you know, with this kind of really complicated variant evolution, Sheena, then what do you think is the future for vaccines? You're on mute.
There had to be somebody, didn't there? So we know that the vaccines that we've already got have helped reduce the incidence of severe disease, and they've also reduced the incidence of long COVID. But what we've seen is that their effects keep tapering off. And so many of us now, particularly those who are under 50 who've had no kind of boosters, are going to be very vulnerable again to the infection. And we also, as Duncan's shown, we know a lot of us are not vaccinated at the moment. And this is not helped by the fact that there was this sort of one-time non-urgent offer for children between the age of 5 to 11 that has now been dropped completely, unless, of course, you are in a vulnerable situation. And of course, that means that we're very different from other nations. And of course, we haven't even thought about vaccinating under 5s, which a lot of other nations are doing. So this means there's an awful lot of people out there that could get COVID. And the more people that could get COVID, I guess that gives it the more opportunity to thrive and potentially mutate. And that's why we see all these variants. So we can't keep offering little tweaks on this original vaccine that we're doing at the moment that keep needing topping up every few months or so. We need a vaccine that can either cope with lots of different variants, so kind of multivariant vaccine, or something that can stop the virus in its tracks when it tries to enter the body, a nasal vaccine. Now, the good news is that these vaccines are actually in development. They're in sort of different stages of development across the world, but we don't seem to be looking at these. And whereas China is now invested in the nasal vaccines and they're rolling them out, we don't seem to be doing that yet. So I really think there has to be an urgent question about what the long-term strategy is to support and invest and test the vaccines so that we can protect everyone.
Thank you. So, you know, those are kind of the challenges facing the NHS and some of the structural issues that we're facing. So what does that mean for everyone else? What does that mean for the community? And I'm going to start with Zubaida here.
Well, I mean, we saw some of the figures that Duncan shared with us, and it is a stark reminder that this has been a pandemic of inequality. I mean, we've said that throughout. We've shown the figures. UK HSA, they've shown the figures. We've seen it in school children. We've seen it in deprived areas versus non-deprived areas. There is that real inequity in terms of exposure, and then there's that real paradox of inequity in terms of protections. And those are protections in terms of people being exposed to the virus, but also in terms of vaccine take-up. And that's really worrying for the autumn, because we can see that uptake. And we know that the government have done very little to address the risks for people in deprived areas, the risks of being in overcrowded housing, the risks of being in public transport, the risk of being on the front line in being much more exposed to the virus. So those risks haven't gone away. We know they're higher for people in deprived areas. We know that children and adults in deprived areas, especially adults, are much more likely to be hospitalized and much more likely to die with the virus, significantly much more, up to 4 times more than the least deprived areas. So all those risks are there, Christina. And vaccine take-up, as I said, as a paradox, vaccine take-up is, or access and take-up is much lower. So I am really concerned. I am really concerned about what will happen to that group who aren't just being exposed, but repeatedly exposed to the virus, which has implications for long COVID. I think the other thing I want to raise is how so little has been done in relation to children. And we know, we've seen throughout this pandemic that children have been repeatedly exposed to this virus, and yet school environment is one of the areas that has had the least mitigations across the sector. And that's extremely concerning, not only for children and the lack of acknowledgement that it affects children's health, that it affects their education, their well-being, long COVID, but also the fact that children don't live in vacuums. Children go back home. They go back home to overcrowded housings. They go back home to multi-generational homes. All of those places have higher risks. So it is very concerning.
I mean, definitely it feels like we haven't learned from the first few years of the pandemic and what we're doing or not doing. So, you mentioned long COVID there. I mean, and like Danny, what kind of are you seeing in your clinics?
Yeah, I think there's still a good steady flow of people coming into the long COVID clinics, and it's just a sort of paradox to me, like so many things in COVID, that we really thought that in a vaccinated population with a so-called milder Omicron variant, maybe long COVID would tail off. Some reports of that in some countries, the countries that perhaps have only had an Omicron wave in Southeast Asia. In the UK, I just don't think we're seeing that. I think we're still, we've still got the cumulative caseload of long COVID from all of the prior waves, and now we've continued to add to it during Omicron. So it's a hard time. So, I just echo what the others have said before me, that my biggest fear for the autumn and winter, apart from the virus itself, is just complacency. I'm surrounded by people who've really borne the brunt of COVID, who've had it time and time again, or have long COVID, or have had people near to them quite seriously ill, and kind of defy the evidence of their own eyes and their own experience and say, but we were told it's over, isn't it over? Why are you still wearing a mask? And that's just, so hard to grapple with. I, like all of us, I travel quite a lot to international conferences at the moment, and I'm the sort of daft one who's wearing my Elephant Man mask with the big tube coming out the front connected to a HEPA filter. And people look at me like I must have some problem. And my only problem is I don't like viruses.
Yeah. Well, you're not the daft one, are you? I mean, that's what it comes down to.
Mm.
So
I'll leave it at that for the moment. But complacency, let's try and avoid it, because you can't mitigate against this by wishful thinking.
Martin, so what is your kind of public health perspective on where we are and what's coming?
Yeah, well, A few weeks ago, we wrote a paper in the BMJ, which we called Britain's Not Working, and it was stimulated by an article in the Financial Times, which looked at the state of the British workforce. Now, I think we're all aware of the fact that businesses are really finding it a struggle to recruit at the minute. Brexit is one reason, but one of the reasons that came out strongly in this Financial Times piece was the fact that across all of the 38 industrialized countries, all had people leaving the workforce during the pandemic, but all but one had seen a recovery back to the trend pre-pandemic. And the one exception to that was the United Kingdom. And we now have 600,000 people fewer in the workforce than we had before the pandemic. And at least a considerable proportion of that is long COVID. We're also seeing other long-term consequences. We now recognize that having COVID increases your risk of death from cardiovascular diseases and so on in the period after it. Quite how long the effect lasts for, we're not altogether sure. But a paper from Singapore showed that this excess mortality was entirely in people who had COVID within the preceding 90 days. Now, I'm actually speaking to you from Brussels, and one of the things I'm working on is a report on long COVID for the European Commission. And that I know is going to get a lot of attention here. I think in Europe, there's this very clear recognition of the need to deal with this, not just for health reasons, but also because of the economic situation. But when we look in the United Kingdom, I looked through our plan for patients that was published yesterday, and basically COVID is not even mentioned. Mentioned to the extent that the Secretary of State thanks the NHS for putting COVID behind us, and it offers the boosters, but that's about as far as it goes. So I think at a European level, we're seeing a great deal of interest. I'll be talking about it with colleagues from Long COVID Europe and with Nisreen Alwan, who many of you know, in Austria next week. A lot of attention here, but I regret that in the United Kingdom, we're seeing far less attention.
Okay, so, I mean, a bit of a depressing picture, I guess, but then like as individuals, are there things that we can or should do? So on that, I'll start with Steve Reicher.
There certainly are, but I think to get people to act, to keep themselves safe, there are two key narratives that we need to address and change. One, many people have pointed out the narrative of it's all over. And it's clearly not. We've heard today that we're at the start of a new wave, but it's not simply that people are getting infected, hospitalized, and still dying in numbers that are too large, but it's having all sorts of other effects. Long COVID, we just heard about long COVID. It's impacting the economy because there are shortages. It's certainly impacting the NHS because of the load and the inability to discharge people who have COVID. So it's certainly not all over. And one point which I think it's really important to remember is that at a global level, it's even more obvious that it's not all over. Low-income countries, still, the number of people who've got a single vaccination is under 20%. In a war-torn country like Yemen, only 2.5% of people are vaccinated. So it's clearly not all over, leading to the greater possibility of new variants. The other thing we've got to make very clear is that when we call for measures, we are not calling for restrictions, and we're not calling for lockdown. Lockdown was yesterday's solution before we had vaccines. Now, with the vaccine, we need other measures which support people and encourage them and enable them. So these are measures like enabling people to stay at home when they're infected, giving them the resources to do so, making sure our environments are safe. And yes, in certain circumstances, in indoors, crowded places, to wear masks. But we're certainly not calling for lockdown. What we are calling for are protections, environmental improvement, making a healthier world for people to stay healthier. So as I say, two key ways in which we need to change the narrative so people realize there's something to be done, but that something is enabling rather than restricting.
Thank you. I just want to echo the clean environments thing. I think investing in clean air indoors is such a massive issue. I was just, as an aside, I was on a train yesterday, 25 minutes on the train. Within 5 minutes, it was over, up to 2,000 particles per minute CO2, which is basically anything over 1,500 is really bad. And the windows were locked shut. Like there were windows on the train, but they were locked shut. And it was just, to me, it's just not a good way to go into winter with that kind of environmental problem. Right, the last word is going to go to Anthony for a bit more of a global perspective.
Unmute. Sorry. Yeah, just 2 quick points. First, the US and 29 countries in Europe are all vaccinating all children between the ages of 5 and 11, but only 2 countries are not doing that and only vaccinating children with risk factors. That's Sweden and the United Kingdom. And the second point is about vaccine apartheid, which Steve referred to. If you look at all, about 1 billion people living in low-income countries, 82%, this is 21 months after the development of a vaccine, 82% are not fully vaccinated, 78% have had no vaccine at all. And when you ask, well, how many people have died in low-income countries, the answer is, we do not know. They do not report their mortality rates. What we do know is in a country like India, the official death rate was around 450,000 people. And the estimates from modelers and from cremation reports and the like was that underestimated by tenfold, so that it was over 4 million deaths. So we've got this, you know, the head of the People's Vaccine Alliance said the conduct of rich countries has been utterly shameful. The EU, the UK, Japan, Switzerland, Canada have all blocked sharing the patent at the World Trade Organization. And now, to add insult to injury, the big companies who are making about $100 million profit per day are fighting. Moderna is suing Pfizer for patent infringement. So they're fighting over profits, and meanwhile, people are dying.
That's a bit of a depressing way to end, but that's where we are, you know, that's the truth of it. So let's move on to questions from the public. So first of all, Nick Turnock, would you like to ask your question?
Hello. Hi. Can you hear me?
Oh, sorry, yeah, it's Nick Turnock first, then Nick Benton.
Oh, sorry.
That's right. Go ahead, Nick Turnock. It's confusing having 2 people with the same name. Nick Turnock?
Hello?
Yeah.
Yeah. My question is about the fact that the hospitals are stopping testing people on admission. And I think the danger is that we're going to miss people who are dying because of COVID, but not by the normally attributed ways, such as they might be dying of heart attacks. And my suspicion comes from the numbers. If we look at the deaths with COVID on the death certificate, they were lower with BA5 compared to Delta at the peak. But if we look at the deaths within 28 days of a positive test, it comes out the other way round. So if we don't test people on admission, we're just going to lose sight of all this data.
So who wants to answer Nick's question? Do I see any hands? Duncan.
So yeah, I mean, it's a very good point that we're not routinely testing people as they come into hospital. So that kind of skews the data. So it goes back to what I was saying earlier about, you know, the amount of testing that's being done means that data is less reliable. So you're absolutely right that there are going to be differences in the way that, that these are recorded. And, you know, what do we know about deaths? Well, there are different ways of recording it. There are deaths within 60 days of a positive COVID test, within 28 days of a positive COVID test. And those are becoming a bit less reliable as the amount of COVID in the population increases. So we're still, you know, the best source is the COVID on the death certificate. And, you know, clinicians may change the way that they, you know, determine that over time. But I think there's another point about not testing people coming into hospital, and that is the amount of transmission that happens within hospitals. So I think that's something that that is pretty significant. There is, you know, data on the amount of transmission within hospitals, which is significant. And I think this is one of the unintended consequences of trying to live with COVID, is that you're preventing that transmission, which causes COVID transmission or, you know, ultimately death. So, you know, these are the costs of pretending, or at least hoping, that COVID has gone away.
Benita, I'm not. Oh, Helen, did you have your hand up? Yeah, Helen, you're on mute.
I think those of us who see patients are just completely flabbergasted by this. So I have patients now who really don't want to go to hospital at all, whatever I might think they need to go to hospital for, because they're scared they're going to catch COVID. And that's actually not an unreasonable worry if they will be set in a ward with somebody else who may or may not have COVID. We don't know. I also think, not testing patients as they go into hospital. Obviously, not every admission is planned, so you may need to test them as they go into A&E. But if we're not then using any precautions and we're putting everyone on open wards with their undiagnosed COVID, we're going to have more patients getting COVID, we're going to have more staff getting COVID, and we will lose track of what's going on, as Duncan's just said. It makes no sense, except as part of a kind of closing our eyes and blocking our ears, let's deny it's still here. It is still here, and I'm afraid I can make no sense of this at all.
Okay, thank you. Benita, did you want to add something?
Just to echo everything Helen has said, I just can't fathom it. And at the same time, we're still not protecting NHS staff adequately with appropriate PPE for all patients, because at the moment, anyone you encounter in hospital could have COVID, we wouldn't know. It just doesn't make any sense, but I think Helen's made all the points.
All right, thank you. And thank you, Nick, for the question. So Nick Benton, would you like to ask your question now?
Hi. My question is, because there's 2 million people estimated to have long COVID in the UK, and we don't currently have any approved treatments, and there's no suggestion, we don't know whether that could increase in the future. Could the urgent public health priority study label that was used for the recovery trial be brought back for future long COVID research to speed up the search for treatment?
I mean, that's an excellent question. I don't know if anyone would like to take that. Danny or Benita? Danny?
Well, I'd like to hear what Benita says as well, but so it's a discussion that many of us have nearly every day, and we go round and round the block. So yes, there were special things done in the recovery trial that we can learn from to get through that kind of glacial pace for getting approvals and for getting these kind of trials into action. But I just add that I do think it's tricky, because for recovery there were some pretty good candidates that that were testable for acute viral infection. If you put a gun to my head and said, name the 10 drugs that you want to try in a long COVID RCT in a recovery style trial, I couldn't name you 10 really, really good candidates that I think would be safe and plausible, possibly 4 or 5 which are currently in trial. So it's not just the kind of regulatory inertia that holds us back. It's just not knowing enough about the mechanism of long COVID, which I guess everybody's working on. I'll give way to Benita and see what she thinks.
Yeah, so Benita,
thanks for asking that question, Nick. It's the $1 million question, really, about why we can't do more rapid real-world studies. And I think I take Danny's point that we don't have 10 really good candidates, but I think there are definitely treatments out there that we know work in some people and not others. So we need that biomedical research to go alongside it to understand, why is this treatment working in this person? And we do have long COVID clinics in the UK that are set up in a structured way that we could do some real world studies on. Not everything has to be a randomized controlled trial to create evidence. And I think we're at the moment, we're doing nothing. We're saying, well, we can't do that, so we'll do nothing. And there is definitely something in between, but it needs political will and funding.
Thanks. And Steve, you wanted to say something?
Yeah, I completely agree with everything Benita and Danny has said. I just want to focus on one particular aspect, because one element of this is that a lot of people are asking, why can't we use antivirals to treat long COVID? Because certainly an element of long COVID does appear to be linked with a long-term persistent infection with that. And this just comes back, and it's a point I've meant to make more of when I spoke earlier. If you treat people with long-term infections over a greater duration with these antivirals, with the current state of play, so drugs that we can really only use on their own, then we know that this virus is going to be able to respond by becoming resistant. And also doing so in chronically unwell patients, immunosuppressed patients, we know that that can also drive evolution of the virus itself. So we have to be really careful. But again, it would be much better if we had better weapons in our arsenal to give combination therapies against this virus, because that is going to be incredibly important going forward.
Thanks. So now we have various questions to read out that have been sent in. But before I do that, someone is asking about your elephant mask, Danny. Could you provide any details?
I wish I could remember the make, but if you, for example, you go onto Amazon and type in mask with HEPA filter, you get various variations on a theme that pop up that are about between 28 and 30 pounds. And okay. I think they're super.
Great. Well, maybe we can tweet a couple later.
Yeah.
You don't have to use Amazon, surely.
Sorry, I apologize. Of course you don't. No.
Yeah, thank you.
I've got no shares in Amazon.
All right. So the next question to be read out is from Martin Saunders, and he asks, basically saying, as Duncan was saying, our data is getting less robust, and we're relying on the ONS infection survey. Is the UK doing any work by looking at sewage, like they are in some other countries? Does anyone know the answer to that question? I'm not seeing any hands. Oh, Steve has got his hand up.
I think, sorry, Danny, do you want to say something?
Well, no, I was going to say one sentence that certainly not at a national level, but Imperial College certainly have a big program for doing it.
Yeah, I think that Danny's right. There are individual studies. I don't think it's ever really been rolled out in this country, and to the extent other countries were. But I think if there were any national programs, they almost certainly have been mothballed by now.
Okay, thank you. The next question is from Jacqueline Hampshire. She says she's a member of support staff in a school, and she's concerned about reinfections this winter. She is under 50, so doesn't qualify for a booster this autumn, hasn't had one for a year. She's continually exposed to COVID in school. She's had it twice already, 3 to 4 months apart. Can she expect to get it once or twice this winter? And what is the thinking on natural immunity? So that's kind of her question. So does anyone want to answer that? She's kind of considering changing career because of it. Danny, I'll go to you because you're our natural immunity bloke, or our anti-natural immunity bloke.
Yeah. So let me do a bit of basic immunology. Yeah. So just very, very briefly, when people have heard me talk before about, you hearing me okay? Yeah. People have heard me talk before about how if you're somebody who hasn't had a booster since last year and you face BA5, you're kind of a sitting duck for infection. And we've all come across people who've been infected again and again and again. And often it's non-trivial, and you can feel really quite unwell for a few weeks. And yet cellular immunology and immune memory are a thing. And hopefully, if you've got an intact immune system and they kick in, that's the reason that you're not hospitalized and not on ITU and not being ventilated, for most of us, most of the time. So your immune response is, we hope, going to see you through. But I guess we don't want to tolerate being incredibly ill and off work and perhaps suffering long-term consequences. Even for those 2 weeks. Why should we? We do need those boosters.
Thanks. Does anyone else want to address that? If not, I will move to the next question. We've got a few more. Okay, so I think this is actually a question mainly for Aris. I'm just teeing you up there, Aris. So the question is, what are the variants we're currently facing? And is the autumn booster effective against them?
Well, it's a difficult question to answer because there are a number of variants that are descended from the BA2 sides of the lineage of Omicron that are mostly circulating at the moment. So things like BA5 and BA 2.275. And the bivalent boosters that are currently being made available in the UK have the other side of the Omicron lineage in their bivalent formulation. So they have the original ancestral strain and BA1, although other countries are doing different things with their bivalent boosters, and how well that will hold up against the various daughters of the BA2 side of the Omicron lineage remains to be seen. I mean, obviously, it will still be always better to have a booster than to not have a booster, but there may theoretically be more optimal combinations of strains that could have been used that might give even better protection on a population-wide level. But we are where we are, and it's still a good idea to have that booster if you're in the group that's eligible for it. Yeah,
I mean, I really hope that they do extend it to everybody, like they did last year, but I guess we'll see. The next question is from Liz Percy. And it's actually, I think a really interesting question that we haven't talked about in a while. And is it pretty well impossible now for younger age groups, and I'm assuming this is children and young adults, to wear a mask because of peer pressure? You know, Danny already talks about feeling awkward wearing his mask. I mean, it probably is harder if you're younger. So does anyone have any thoughts about that? Maybe Steve? Right here?
Yeah, so, I mean, first of all, the problem is, again, that we are in a context where we are told that, you know, there is not a problem, there's not a risk. And if you look at the literature, one of the key factors is perceived risk. But even more for young people, the point is that if you think about individual risk, they are at much lower individual risk. We've seen the figures throughout that in terms of serious disease, age is a major factor, which is why it's so important not to think in individual terms, but to think in collective terms, to think in terms of we, the community. Because if you think in terms of risk to others, then you going around without a mask could lead to somebody else in the community getting infected. So particularly for young people, it's not only the narrative of it's all over, it's the narrative of personal responsibility, which misses the point that the key factor, and there's a lot of research on this, which explained adherence was a sense of community identity, shared identity, concern for others. And when you talk about personal responsibility, it's up to you, let everybody decide for themselves, then you create a situation in which people do simply think about themselves, don't think about the community risk. So I think there are a variety of factors which explain the lack of mask wearing. I go back to the narrative of it's all over, and I go back to what we previously said about the dangers of talking in terms of personal responsibility, making this about me rather than talking about we. And we have again forgotten, and this is yet another factor in terms of the narrative of it's all over, we've forgotten the millions of vulnerable people who are affected, who in effect are locked down, the only ones who are locked down because it's dangerous to go out. And we need to think as a society how we create a humane society where we act for each other and make sure that everybody can participate in society. That's where I put my effort. I wouldn't put it down to some sort of generic aspect of being young, which is a pessimistic position which says we can never change things. What we saw in the past was that young people were quite remarkable and quite magnificent in acting for others in order not to infect them. And we've lost that, and we've got to get it back.
Great, thank you. Does anyone else want to answer this? Zubaida, I just want to ask you something, because I'm just wondering whether the communities that are already disproportionately affected by COVID and already marginalized, is this, you know, is the messaging that it's all over and it's all down to individual kind of alienating those communities more or not?
Well, I was going to say, it's not just about alienating, it's actually harmful. It's putting them at much higher risk of being ill, of being severely ill, of dying from COVID. I mean, I was just thinking back in December last year when Omicron was just rolling out, and Independent Sage were really concerned about Omicron and the lack of protective messages around Christmas. And one of the areas where it was pretty bad was in London. Now, London has high proportions of ethnic minorities. Over 40% of London has BME populations, but it also has extremely high rates of deprivation. So you've got deprivation, you've got ethnicity, you've got vaccine inequity issues, all of that, and of course overcrowding. You know, Newham has some of the highest rates of overcrowding in the country. You have all those factors, if you like, the perfect storm of factors for being really at risk from COVID. And I think that's what's concerning. And on top of that, we were talking about children in schools. Now, a third of children in secondary schools, a third of children in primary schools, a quarter of children in secondary schools are from VME backgrounds. And yet there are no protections. You know, they're going back home with COVID. So there are some real concerns about that. And I understand what you're saying about alienation, but I think it's actually much more serious than that. And I just don't know. I don't know what more can be done other than, I just want to say, and I've been saying this throughout, we've all been saying this throughout, there needs to be a better national campaign on vaccine take-up, targeting particular groups. Those risks haven't gone away, and that national campaign never really happened.
Okay, thank you. Steve Griffin, you also wanted to come in.
Yeah, I mean, I completely agree. And the altruism element is for me incredibly important, because I've always felt that clinically vulnerable people are always neglected. And, you know, coming back to what I said about Evershed, I think there's a real missed opportunity there for people to get their lives back. But it strikes me that we're often accused of just talking about COVID and SARS-CoV-2. And, you know, I think a lot of the antagonism against masks and other precautions have been about that idea. But what strikes me is about, you know, the precautions that we took, and they needn't necessarily be an imposition, didn't just affect COVID. They affected influenza, they affected norovirus, they affected rotaviruses, they affected all sorts of different childhood illnesses and adult illnesses. And the cleanliness of the air would help people. All of these sorts of things that we can do to improve our national response against these sorts of illness would have profound benefit across the board. And so I just don't understand why even the most, you know, this is all over type economically driven person doesn't understand the value in that. And I think that's just a real source of frustration for me.
Okay, thanks. And Helen just wants to come in as well.
Yeah, I just want to come in on behalf of that poor teenager or whoever we're talking about, actually, how difficult it is to be the one that's behaving not like everybody else, because I think it's really, really hard. I mean, I work in a medical setting, and we're still having to have conversations about, do we keep masks going here, even though everybody else has given them up everywhere else? And that's us in doctors in a medical setting. How much more difficult is that for a teenager at a school to stand out and be the only one? Really, really hard. And I suppose one of the things I would say would be the first to, if you do have any symptoms at all, if you've got a runny nose, if you've got a sore throat, think, I might be catching, I'm going to wear my mask, so that when people ask you, say, it's because I think I might have COVID, or I have got COVID and I don't want to give it to anyone else. I think it's hard to be the brave person who's going against the flow and not fitting in. You will have huge admiration from some people, but I absolutely recognize that it's difficult, and it's hard for individuals to do that on their own. I think if I was a teenager now, quite glad I'm not actually, if I was a teenager now, but wanting to look after myself and my family and those around me, I would be thinking, okay, where is it most important that I wear a mask, or where do I just not go? And I certainly would wear a mask on a crowded train, and I would think twice about a crowded gig, and think about, you know, where am I most at risk? One of the problems is you might be most at risk at school, and it's very difficult to know what you do then. But I'm just giving some empathy to those teenagers, because I think it's really hard.
All right. Thank you. I think that is the last question we had time for. I just want to add one thing. So I do always feel really awkward when I'm the only one wearing a mask. And one of the reasons I keep doing it is actually I've had COVID twice now. And one of the things that I was so grateful for both times I got it was that I was wearing a mask. And so I felt, thank God, before I got symptoms, that I was wearing it. And I feel confident that, well, I'm much less likely to have given it to other people than I otherwise would have. And I would have had no idea that I was potentially infectious until actually, a day or two after my symptoms started, because they're so weird, like they're so mild when you first get them. You don't even think about COVID. So if you just wear a mask all the time in like public transport or shops, it just kind of takes that kind of burden away from you, of you thinking maybe I'm infecting other people. So that's kind of why I keep doing it. So that's kind of just my personal reflection, but that's all we have time for. Thank you so much for your questions. Thank you to everybody for your great challenges today. And we'll be back next week, same time, same place. So keep safe, everyone, and goodbye.